Hi, this is Tony Ward, and I'm an Associate Professor of Health and Counselling Psychology at the University of the West of England. And this is a short presentation that I put together to help students to revise the psychological principles around substance abuse. So, substance abuse is a big problem. If you look at statistics from over 10 years ago, for example, we know that over 10% of pupils were smoking regularly at that time. Other substances, such as volatile substances, have been a problem. This graph shows data from the 1980s and 90s, showing many hundreds of deaths due to volatile substance abuse. Young people have been shown to use a whole variety of substances. Looking at this data from 2012-13, we can see that the most abused substance is cannabis, closely followed by alcohol. Note that these figures are based on the substances used by young people in treatment. If we want to find out whether somebody has a problem with substances, there's various measures around. For example, the CAGE questionnaire published by the American Psychiatric Association, which includes questions like, have you ever felt that you should cut down on your drinking? And this is about alcohol, obviously. Substances have been abused throughout human history. Going back 6,500 years, we have evidence that alcohol was being used. 3,000 years ago, marijuana and opium were being used. Right through early history, evidence of cocaine, marijuana, opium, alcohol, caffeine around 900 AD. Right through into medieval times, tobacco becoming very popular, alcohol being distilled in the Americas, opium, cocaine being used during the colonial times, 1600 onwards, caffeine being used more widely. Taxation of caffeine and tea from 1773. Opium being widely used in China during the 1800s, and so on. Notice here 1827, the American Temperance Society becoming quite influential as people became quite concerned about abuse of alcohol. And right up to the modern day, pardon me, of course, from the 1950s and 60s, Western societies have moved to prohibit some of these substances. And if you want to find out more about the history, here's a link that you might follow. So what are the general principles around psychology and addiction? Key principles to remind ourselves of are physical versus psychological addiction, the notions of tolerance and withdrawal, positive and negative reinforcement affecting substance abuse, craving and relapse, and brain mechanisms and changes. So various key drugs, alcohol, cannabis, etc., all known to have physical effects on the brain to affect particular brain processes. Alcohol, for example, influences NMDA receptors and is an indirect antagonist of GABAergic neurons. Nicotine influences the acetylcholine system and is an agonist of acetylcholine. So, because drugs are known to produce these identified biological effects, one theory around substance use is that people become tolerant of these substances and require more and more to get the same effect. And when they stop taking them, they then get a withdrawal effect. Now, alongside that is also the notion of psychological addiction. These substances are generally pleasant to use, and therefore people come to rely on them psychologically because it may make them feel better or less tense. So, as we've said, tolerance is people adapting to the drug, therefore in future they will need more of it. And if they don't take it, this will cause withdrawal effects, which will make people feel uncomfortable and therefore want to take more of the substance. Some drugs can produce tolerance, in other words they need more, but they aren't necessarily seen as addictive. Beta-adrenergic agonist inhalers, for example, that are used in asthma. Some other drugs are highly addictive but don't appear to produce significant tolerance and withdrawal, for example cocaine. And part of the problem in drug abuse is that heroin has tended to be used as the model of addiction. Pardon me. So, positive reinforcement, the well-known psychological principle: if something produces pleasant effects or leads to positive outcomes, then it will increase the behaviour, particularly if the reinforcement is immediate. Logan 65, for example, showing that rats would rather have a small amount of food now rather than after a delay. Most addictive drugs, therefore, are seen to have immediate effects. The effect of heroin is very rapid and often preferred to morphine for that reason. Vicarious reinforcement. This is around the issue that a drug may have an effect that's delayed, but it can still have an impact on behaviour through that delayed effect, because we as humans have memories and we can remember that we did take the drug, and we can ascribe the drug to the delayed effect. That's less likely to be seen in animals, and that perhaps is due to animals not being able to link the drug with an effect that occurs some considerable time later. Various neural mechanisms have been put forward. Dopamine in the nucleus accumbens seems to be necessary but not sufficient condition for reinforcement. Dopamine widely implicated in lots of reinforcing behaviours, around appetites, for example. Addictive drugs all seem to affect this system. Now, the opposite of positive reinforcement is negative reinforcement. Negative reinforcement being the removal of an aversive stimulus. So if you feel very anxious all the time and a drug makes you feel more relaxed, then that is negative reinforcement. Often not quite what people expect it to be. People sometimes confuse punishment with negative reinforcement. So, one of the problems we have in addiction is that people can become abstinent and then many, many months later they start taking the drug again. So why do people revert to drug taking? And various theories around this. Robinson and Berridge, for example, suggest that stimuli in the environment that remind you of the drug can activate particular pathways in the brain, and this then prompts you to take the drug. And therefore a small amount can prompt a full-blown relapse. So an alcoholic, for example, who sips a small amount of alcohol to party may then go on to drink a considerable quantity. PET studies have shown that the orbitofrontal cortex at the front of the brain is involved in craving. People starting to feel that they would like to take the drug again. Long-term changes in brain function have been observed. Rats have been shown to relapse under stress. Pardon me. A couple of studies cited here around rats and relapse, showing the role of stress, therefore. So if somebody is stressed after having been absent for several months, they may crave the drug and then relapse. So common drugs of abuse we've already mentioned. Opiates derived from poppy, very addictive, quick tolerance. The tolerance then often leads people to injection, and because these drugs can get into the bloodstream of neonates, babies can often be born addicted to substances such as this. It's thought that there are natural opiates that are secreted at times of stress, which reduce the effects of pain. Neural basis, various parts of the brain have been shown to have opiate receptors in them, for example the periaqueductal grey matter, which leads to the analgesic effect, the preoptic area, which leads to hypothermia, etc. And 3 different types of opiate receptor have been identified: mu, delta and kappa, which reflects the fact that there are these various effects in different parts of the brain. So the first 2 receptors being linked to analgesia, and reinforcement. Pardon me, the latter being aversive. It's possible to knock out the mu receptors in mice, which makes them unreceptive to opiates, which is interesting. Dynorphin, endogenous opioid, stimulates the kappa and is aversive. So reinforcement, it comes again, as we've mentioned previously, from dopamine in the nucleus accumbens and mesolimbic pathway. 150 to 300% increase in dopaminergic receptors and transmission when rats are taking heroin, for example. So we've just said that the reinforcement in the mesolimbic pathway may be responsible for the addictive properties. And evidence for this, you can do a chemical lesion of some of those pathways with cyanuric acid, which prevents rats from developing a preference for amphetamine, but they still develop a preference for morphine. So opiates may not need to trigger dopamine to release and reinforce behaviour, according to that study. So role of endogenous opioids in reinforcement, study here by Agmo et al., using various chemicals to block either opiate or dopamine receptors. Evidence of the neural basis of withdrawal effects. Again, various regions implicated. Maldonado et al. Showed that morphine-dependent rats injected with naloxone in various brain regions to see which would precipitate a withdrawal response, and the locus coeruleus was found to be the most sensitive. And so there's been most effort looking at that particular region. The opiate leads to decreased firing, chronic administration leads to normal firing, withdrawal then leads to rapidly increased firing, and so that change over time in the pattern of activation is thought to lead to the withdrawal processes. A study here by Maldonado et al., again looking at mice with mutations of genes for Krebs production, have a usual response to morphine due to the analgesia effect, but a much less reduced effect to antagonist precipitated withdrawal. So Krebs seems to be important in influencing those withdrawal effects. Heritability of drug use. Most of the studies around heritability have tended to look at alcohol. Obviously, it's a widespread substance of abuse. It represents a very big social problem. Twin studies have suggested that alcohol and nicotine have genetic factors in common. True et al. 1999. Beirut found common and specific factors to a range of substances. And therefore, maybe there's a common tendency, such as an addictive personality, question mark there indicating that that's an interesting concept, quite controversial. What exactly do we mean by an addictive personality? Plus perhaps specific weaknesses. Evidence for this comes from the fact that 10% of people drink 50% of the alcohol that gets consumed, so a small number of people drink large quantities. Cloninger et al. Looked at adoption studies, found that heredity was more important than family background, i.e. having an alcoholic parent. Pardon me. So the point there is that if your parent was an alcoholic, but you were adopted into a family where the parents are not alcoholic, you still have an increased risk of being alcoholic yourself. And Cloninger differentiates between steady drunks and bingers. Different types of drinking patterns may have different implications. A steady, heavy drinking pattern is more heritable, apparently, for men. Women tend to develop somaticization disorder, according to Cloninger. So binging is a combination of heredity and environment. Personality and behaviour differences suggest underlying differences in the brain basis between different people. Steady drinkers crave excitement, have an underactive reward system, and are less sensitive to punishment. Bingers are more introverted, able to inhibit drinking, but experience a release of tension when drinking, and the inhibition of the abstinence motivation makes them unable to stop. there is a need to look at these various issues for some other substances of abuse. For example, nicotine, cocaine and cannabis have not been particularly well looked at. So having reminded ourselves of some of these key psychological principles around withdrawal, tolerance, positive and negative reinforcement, relapse, etc., what I'd like you to do now is to have a look at the case of Alan with Bardia, which you can find in the psychotherapy database. And there's a transcript of this case provided in Blackboard if you would prefer. And I'd like you to just look through the case and consider the extent to which Bardia's issues and problems, as she describes them, can be explained through reference to these various psychological principles, and then we'll go through this in class as a way of revising the concepts.